Hello, everybody, and welcome. Welcome to the BC Health Coalition's second panel for a vision for public mental health care. I'm going to start off with the land acknowledgement. Thank you. We acknowledge that we are here today on the Coast Salish nations of Musqueam, Tsleil-Waututh, and Squamish territory. We also acknowledge the many territories and lands across Turtle Island that you are joining us from. We are honored to be here as guests on this land that Indigenous peoples have cared for and continue to care for. We invite you to take a moment to think about where you presently live and honor the people of the land. Think about your relation to the work, your relation to the place you live, work, and interact. This is our inquiry to honor the past and present and to stay connected to decolonization practices. We invite you to use the chat to share the name of the territory or land from where you are connecting from as part of this acknowledgement. Thank you. So again, welcome everybody. My name is Tanya Patterson. I am one of the co-chairs on the BC Health Coalition Steering Committee. I'm also the health sector coordinator for CUPE members here in British Columbia. I am accompanied by my friend Edith McCaddy, also co-chair of the steering committee and an HSA member who works as an occupational therapist in a child development center in Surrey. So just a couple of housekeeping things before we jump into things. This event is being recorded. A link to the recording will be sent to webinar registrants within a few days. The video will also be available at bchealthcoalition.ca. Please note that the chat will not be monitored today. So to limit side discussions to minimize distractions. There will be an audience Q&A after the panel discussion. You can submit questions for the panelists at any time during the event by using the Q&A function at the bottom of your screen. Questions posed in the chat will be missed. We apologize in advance if we're not able to ask everybody's questions. I'm seeing lots of land acknowledgements come in through the chat, so thank you to everybody that's doing that. So I just want to quickly touch on the fact that we acknowledge that these discussions and discussions in general about mental health may involve sensitive topics and can be very difficult. We honor the risks that our panelists take in sharing their experiences, and we encourage all of you to practice self-care and take any breaks that you may need from the discussion. We've also compiled a list of mental health resources, and there will be a link put in the chat for you to access easily. So last month, the Health Coalition hosted our first mental health panel. We invited 4 workers to share their experiences of working on the front lines during the pandemic. They came from retail, community, counseling, temporary modular housing, and hospital. They shared challenges and mental health pressures that they have experienced with their colleagues during the pandemic. It was clear that COVID-19 has impacted mental health, safety at work, and that workers, especially those on the front lines and in essential services, need more mental health support to continue doing their work sustainably. Our panelists also made it abundantly clear that mental health is not simply a workers' issue. Last month's panel revealed how workers are increasingly concerned not just for themselves and their peers, but also for the general public they serve. They spoke of a noticeable change in the mental health of people they encounter while at work. And we know that mental health was a growing concern even before the pandemic, and that 38% of Canadians say their mental health has declined since the pandemic has started. Despite the growing need, it's incredibly difficult to access mental health care. Many BC residents don't have access to mental health care coverage, and most can't afford to pay for it out of pocket. Even for those who can afford it or are lucky enough to find low-cost programs, long wait lists present yet another barrier. There's a large body of evidence that shows that it's more effective to treat mental health early on as part of primary care, and that social determinants of health also contribute to mental health. Yet in BC, care often only kicks in once individuals reach a state of crisis. One of our panelists last month reminded us that our public health care coverage strangely doesn't care for our mind. It stops at the neck. It's time we reimagine how we think about mental health care and its role in our public health care system.
Great. Thank you, Tanya. Edith here. I'm so happy to be one of the co-hosts of this event, and we're so excited to welcome 4 amazing panelists today who have thought deeply about mental health care and have lots of experience working on the ground and on systemic levels. We're so grateful, as Tanya mentioned, for their willingness to share their time and expertise with us, as we have a lot to learn about these topics. And so we'll jump right into the panel, but at the end, we will have a few closing remarks and also an exciting call to action campaign run through the BC Health Coalition. So we're going to introduce our panelists. As I mentioned, you'll hear a bit about them. And we will have time for the audience Q&A at the end. So please use the Q&A function at the bottom of your screens to submit your questions at any time in the process. So now I'm pleased to introduce Adrienne Young. Adrienne Young works at Community Action Initiative as a grants manager for community counseling projects. They serve as a member of the BC Health Coalition Steering Committee, Community Caucus. Their background includes work in youth education, health systems navigation, and queer and trans healthcare. Thank you, Adrienne.
Thanks, Edith. And thanks so much to everyone for joining us today and reimagining a more equitable public mental health care system. So I'll just jump right into introducing the panelists. So first up, Kendra Mill is a lawyer and the executive director of Health Justice, a nonprofit that works to support human rights in coercive mental health and substance use care. Prior to leading research and advocacy related to mental health and substance use, she has worked on issues related to poverty, housing, and gender equality, with a focus on the intersection of health equity and human rights. Second, we have Arthur Paul. Arthur Paul supervises the mental health and addictions counseling programs of the Native Courtworker and Counselling Association of BC. Arthur is the clinical supervisor and holds degrees in clinical counseling, business and administration, criminology, and psychology from the Universities of Washington, Victoria, Simon Fraser, and UBC. Next is Shobha Sharma. Shobha has dedicated her professional career to community development. After completing a master's degree in Indigenous governance at the University of Victoria, her passion for human rights led her to engage in Indigenous dialogues, responding to globalization and governance on Turtle Island and abroad. She is currently the executive director of Central Interior Native Health Society, an integrated healthcare center committed to providing an equity-oriented healthcare model, honoring the interface of Indigenous and non-Indigenous worldviews. And last, we have Jonny Morris, who is the CEO for the Canadian Mental Health Association BC division. He comes to this work with personal and family lived experience. So we have 6 questions for folks today. Just to start off our opening round, I'm wondering if everyone can just go around and share a quick peek into what keeps you up at night. So what has captured your attention as a nonprofit leader in mental health care? So anyone who wants to start, feel free to take that and we can go around.
I'd be happy to kick things off, Adrienne, because I think I suggested that question. So I'll just get going. I do want to acknowledge I'm joining you from unceded and ancestral Lekwungen speaking territories today, and the Chartered Association of the Métis Nation of Greater Victoria. What keeps me up at night? I would say we, at this point in time, briefly, we are at such a profound convergence. Mental health is literally top of mind because there has absolutely been a leveling of distress related to the pandemic. We have an ongoing drug poisoning crisis. We're grappling with the impacts of climate change, and of course, have witnessed and tried to do our best to support Indigenous communities who've been grappling with the confirmed findings of recovery of children from former residential school sites. And so what keeps me up at night is do we have the frameworks collectively to navigate the terrain that lies ahead of us, whether that be resources, funding, the kind of thinking and expertise, bringing people with lived experience into designing the approaches we need to go forward. I was on a call about the flooding this morning, and the profound impacts there that on commodity workers, agricultural, Indigenous communities, what's happened across Sumas Prairie this past week. So we are at such an important juncture, which requires, there's a moral imperative for us collectively to get this right as we go forward and try to remove all of the obstacles and the barriers that have existed for many, many years that create inertia around what we can do to put mental health on a more equal footing with physical health and other forms of health. So I'm just contemplating, do we have what we need to work together, given the convergence of what we're collectively up against right now with regard to what's above the neck, our mental health and well-being. Thanks, Adrian.
Thanks, Jonny. Kendra, Shobha, Arthur, love to hear your thoughts. What's keeping you up at night?
It's Arthur Paul, program manager of the Indigenous Counseling program. And I think what keeps me up at night is the context of retirement. First of all, what kept me up at night is this speak, this talk, this presentation. It was like, oh my God, I'm stressing, and I got white hair overnight. The biggest piece of that keeps me awake at night right now is just the retirement and what pretty much retirement specifically means, and the succession planning that we've set up for the organization as a whole, and what for this program as a whole, and where we're going to go and how we're going to get there, and if there's enough money to actually continue on with our resources and services that we get to support those that we serve. And then the biggest piece is those who we serve and the intergenerational traumas that's actually happening, the generational traumas, the children of incarcerated parents, the single moms that need help, the elders that are out there that are being overused and over abused, and just trying to find some extra dollars on a continual basis for those who we serve. And it helps. I just kind of going, I can't retire. I'm going to continue on working, and I'd love to, but at the same time, I'm kind of going, it's somebody else's turn after this, but what do I do when I retire? Well, we've been talking about skydiving and rock climbing and going back on my motorcycle and riding that and trying to take time off, and how much golfing I'm going to be doing in the near future. But I don't know if I'd be really happy with doing all those things, because my mind is always working on who we serve and how we can improve that. And like every one of you, it's embedded in your blood, and you just can't get rid of it. But that's mine. I was dreaming about talking about this talk today, and was dreaming about what are things I was going to say, and I wrote 4 pages of it, and I went, okay. Adrian has been very, very supportive and given me ideas of what we can talk and share about. But yeah, keeping me awake. Eye operations, physical self-care. Thank you.
Thanks so much, Arthur.
Howdy, everyone. Susie Shobha, Executive Director at Usli, Central Interior Native Health Society. I'm coming to you today from the unceded and traditional territory of the Lheidli-T'enneh. What keeps me at night? Really great to hear you say, speak Arthur and Jonny. And I would say that for me, thinking about what you're saying, but also, and I think it's all related, is the interface of different worldviews. I think that you know, we're hitting this time, and this is something that many have known for a long time, is we can't inform others with our thought process. We can't force others with our own thought processes, but the world is now putting us in a place in which if we don't have a paradigm shift, we're not going to be able to sustain, you know, sustain ourselves, being able to fight this great fight. But also inclusivity means being able to honor other ways of doing things and incorporating them. There's never just one way, there are many ways. And so echoing everything that you've said, how will this continue? I would say in every moment and every day, my thought process is when is everyone going to get there? And I think forums like this are an opportunity to help to share that, to spread that information in regards to there are other ways of doing things. Not one way is perfect for all. And so I always come back to what truth and reconciliation really means. And, you know, we understand what the truths are, but what does the reconciliation process look like? And that's for even what we're dealing with the ecocide right now. Like what are we doing, and what are we going to do to be able to sustain our future generations? As a young mom of two, it's what I think about every day. What can I do to make sure that they're going to have a healthy world to raise their families in, or to be part of a community that's not suffering. Thank you so much. And I pass the honor over to you, Kendra.
Thank you so much. I love hearing from everybody. My name is Kendra Mill, and I work at a relatively new organization called Health Justice. And I'm joining today from the unceded territory of the Squamish, Musqueam, and Tsleil-Waututh people. And I think everybody, I sense this will be a theme here, but I think everyone probably has wiser thoughts than I on this front. But I will say, at Health Justice, we work purely, and we don't deliver services, we work purely in systems change. And systems change related to folks who are experience just incredible marginalization. So we work in support of the human rights of folks who often are deemed by the health system to be unable to make their own decisions, and have the health system take over and start making healthcare decisions for them. And in doing that work, we really try to explore all different perspectives. It's an incredibly complex system and a complex situation for people to be in. And so we hear from people with lived experience who have been just deeply harmed by the way our system works now. We hear from family members who needed their family, or really, you know, saw their family members needed help. We talk to frontline service workers about what it's like to be playing a role in that system. And to be honest, what keeps me up at night is I really believe it's so generous. It's like the height of generosity for me, for people to share their stories and experiences, particularly when they were deeply traumatizing and harmful, in order to try to make systems change for other people. And so it keeps me up at night, like our ability to carry those stories well, both as an organization and as an individual, but also as a community and a province, to sort of have that generosity when people are willing to share their expertise and experience, go to sort of what everyone was talking to, and sort of creating meaningful change in the system. And I'm always up about sort of whether I'm doing all I can to make that happen.
Yeah, thank you. Yeah, thanks so much, Kendra, and thanks so much to everyone for giving us that brief look into, you know, what's going on in your heads, you know, what's preoccupying your days. So our next question is kind of foregrounding this discussion in the reality of what's going on right now. And so I'd love to direct this question to Arthur and Shobha as leaders in community. So I'm wondering, can you tell me, from what you see in your communities, what does the situation look like in terms of accessing mental health care supports? So what are the largest barriers that you're seeing in the system for someone who's trying to access it?
Jonny, did you want me to go first?
Sure.
Okay. Thank you, Adrian. I would say in terms of mental health supports here on the unceded traditional territory of the Lheidli T'enneh and I think this was touched upon in the last session that you had, is the sheer amount of mental health clinicians. There are super long wait lists to get into appointments to see you know, traditional mental health clinicians or wellness counselors or supports that can provide mental health in a traditional sense. But there's also huge barriers, especially for those that we serve in regards to access, displacement as a result of colonization, and what that looks like currently in terms of the amount of homelessness, those that are precariously housed, so those that are struggling to keep housing. It's really difficult for continuity of care when you don't have a permanent space. It's very difficult to be able to continue on and working with someone on a health and wellness journey when you can only see them once, or there's disjointed visits, and or there's too long time that has passed between. So I'd say the continuity of care piece really is challenged by displacement. I'd say the other piece, substance use, poverty as a whole, there's so many aspects, but really encourages no-shows. And so we can work really hard to book people in, but our rates of no-shows are so difficult. And part of how we manage that is we have a robust outreach team that goes in and brings people into care. But again, it's a huge challenge. It's something that we have to put a lot of resources into ensuring happen. And our office operates, or our center operates, with a harm reduction approach, but not all offices do, not all traditional practices do. And as a result, one of the greatest barriers is trying to explain to other service providers the social determinants of health that exist around the client that you're serving, how real the impact of colonization is. Colonization has not left. And as a result, the violence and the ramifications of colonization still exist. That still exists in the number of suicide rates, the amount of substance use, the amount of individuals that are trying to cope through trauma, through substance use, and the number of mental health, and even displacement itself is a direct ramification. The transitioning from reserve to urban centers, all of that diaspora has everything to do with colonization. And as a result, it contributes to the need for education around those places, or in different spaces that are providing that care. I feel like that's a huge barrier. We still haven't gotten to the point in which people really get it. And as a result, there's compassion, but there's also a reflection in their services, trying to adjust and admit, and trying to meet clients where they truly are at, meet families where they truly are at. I'd say the other largest barrier are Western forms only of mental health supports. So what does mental health support look like in other cultures and in other communities, so that we actually can create sustainable change for clients? So I think it's also around the concept of what mental health means and how we then address it.
Yeah, thank you for the insight, Shobha. When you were speaking, I was just reminded of that fantastic article by Eve Tuck, I believe, called "Decolonization is Not a Metaphor." So yeah, everything you're saying is just spot on. Thank you. Arthur, I'd love to hear what you have to say about barriers that you're seeing in the system.
A lot of the, thank you. Wonderful ideas that came earlier, just comments. The barriers that we're facing is yes, First Nations Health has actually provided quite a few qualified counselors specifically to provide mental health counseling to individuals that we serve. And we called all 200 of them here in Vancouver. And out of 200, we have 53 that specifically have some experience in working with Indigenous and non-Indigenous people and mixed couples and status, non-status, and or Indigenous and Métis individuals. The issue is exactly that, is that individuals have some service or understanding of Indigenous and non-Indigenous individuals, Métis and Inuit, and the understanding and the difference between status and non-status. That's a huge barrier. I mean, we have First Nations Health who says, yes, we can provide those services. We're giving you 200 individuals, but I've got 53 out of the 200 who never answered any of our questions whatsoever. And out of 200, that's quite a few therapists that we have in the field that First Nation Health has actually said, yes, you're qualified to provide services for our Indigenous individuals. Right now, I know of 16 individual therapists in the field who are working one-to-one, who are Indigenous and that are working, and we use them quite a bit. I have 2 therapists that come into my office every twice a week. They're in here just a couple of minutes ago, and they have an extensive waiting list. And I keep trying to add more onto them, and just like, we'll take as many as you can, Art, but we can't get to all of them. So that enhances the waiting list. One of the areas that we really found is that we're limited because one of the our Vancouver service, we're not allowed to deal with sex offenders or those who are charged with sexual offenses and domestic violence offenses. So that really limits the service that we can provide to individuals, specifically because they're still looking for somebody else to be able to provide the service. And if we can't, who can? Hence the other 200 therapists that we talked to, and the 53, I think that was one of the questions that we'd ask them. Would you take a sex offender? Would you take somebody who has violent tendencies and have been charged with domestic violence? So I can understand them not responding and not wanting to be a part of it, but at the same time, that's the biggest black sheep of our family is the sex offenders. Nobody wants to work with them. We talk about child apprehension is the biggest piece. We're not supposed to be working with 18 and under, is what we're told was a fund for one of our other funders. Well, you can't work with one. You can't work with just Joe and just Jane. You have to work with little Joe and little Jane in order to make sure that you have intergenerational teachings for all of the full family. And all our elder supervisors are pretty much saying the exact same thing, is going, you have to teach everybody. Everybody has to have healthy communications and healthy families. Well, when you're limited in that format, it makes it difficult for mental health addiction and mental health and addictions to be taken care of. So those are the 2 pieces that I have. I look at for me right now, it's just, I hate to say it, but I'm one of the culprits that are out there. I abuse my elders because I ask them to take on a lot more clients than they actually can. And because of their loyalty to our community and to those we serve, they're going yes, and they call and they work beyond the hours that they work. And I abuse my staff members because they work beyond the hours that they're supposed to be working. But yeah, mental health, huge one. Very few people like to take it on. That's as much as I can right now, because it's just there's too much. Keeps me awake at night.
Arthur, thank you. I'm hearing that there's both a lack of understanding and some rigidity from the funding side of things that kind of restricts your ability to provide holistic care that is needed intergenerationally, intersectionally, and then that there's a lot of just overwhelm among your staff and the elders that you're working with, because community is often a last resort, and it sounds like you're getting really loaded with referrals, perhaps in a way that shouldn't be. And my next question is for Kendra. So Kendra, you're doing some amazing work with health justice where you've taken a deep look into the Mental Health Act and how it enables coercive healthcare. I'm wondering if you can help us right now to understand the disproportionate attention and resource allocation of public mental health care resources to crisis-based and coercive health responses as opposed to primary healthcare. So another way of asking this is, if funding and policy was more balanced, what could it look like?
Yeah, thank you. I mean, I guess I would say start the conversation by saying everything we've heard in conversations today about the sort of inadequate resources, both in terms of sort of funding and just sheer access to humans who are have sustainable workloads to do this work, and access to culturally safe and truly accessible services. One thing that I think surprises a lot of people is we're actually seeing incredible increases in the use of involuntary treatment in BC. And I think in large part that's a symptom of the fact that we don't have adequate community resources and resources to help people before they're in crisis. There was an article in the TAI yesterday about how over the past 13 or 14 years, our use of detaining people in hospital and treating them, providing psychiatric treatment against their will, has doubled. So I think it's really useful to think about why is that method of getting folks help and support becoming increasingly relied on. And I think it has a lot to do with the fact that we're not offering services that are truly accessible in all the ways that accessibility can mean, and available in communities throughout the province. And so we're seeing, in terms of crisis response, increasing police apprehensions, increasing use of wellness checks, increasing detention, as I said. I think it's useful to explore what the impacts of that are, because it's certainly a system that intends to help people who are in deep need of help in that moment. But what it means, we hear, is that it's often, our ability to, our bodily autonomy and our ability to make our own healthcare decisions are fundamental to our human dignity, and they're one of our most basic human rights. And when those rights get overridden, that is often a deeply traumatic experience for people. And so what that means is that people who've had that experience often end up experiencing additional trauma in addition to the healthcare needs they had when they sought help or when they were hospitalized, that often ends up alienating them from services in the long run. So in that moment of trying to help them in crisis in the moment, we often end up having folks that are incredibly fearful of accessing health services, and for years afterwards will actually avoid proactively accessing not even just health services, social services as well, for fear of that process happening to them again, which of course doesn't help them with preventative healthcare, right? It just leads to this escalating cycle of crises often, where each time they're in crisis, more and more use of force is needed because they're more traumatized by the experience. And so I think it's really important to have that be part of the conversation, because I think the way we think about systems now, we often think about individuals being sort of problems in communities or individuals in distress. But I think it's really important that we think at a systems level at what about our systems are causing increasing numbers of people to be in that level of distress, because we need to take so many steps back to understand that, because it has immense impacts. We know from other jurisdictions, even though BC doesn't keep data, the use of this type of coercive healthcare is disproportionately experienced by Black, Indigenous, and racialized communities. Use of force rates within that process, again, is disproportionately impacted by racialized communities. And so there's just this incredible need to investigate why we're so heavily relying on crisis care. And the other piece that we don't talk about very often is the impact on frontline staff. I don't think most healthcare professionals got into their work with the hopes of their sort of primary role being dealing with people in incredible distress in an ER and then putting them in a seclusion room. So we see the impacts sort of throughout the system of our incredible reliance on this approach. And in terms of what a different system could look like, I think everyone else here is talking about that. I think it's from a legal perspective, I think there's immense work we could do to make sure that the legal regime we use in order to, which is the Mental Health Act in BC, that deems when someone can be subject to involuntary treatment is updated to reflect modern practices. Much of it is from the 1960s still. And that we take a human rights-based approach that centers that communities and individuals often know what they need best. And that is a valid form of expertise. And it doesn't displace medical expertise, but those are all valid forms of expertise that need to come into the mix. And I think if we start to take that lens in how we design services, we're necessarily going to end up sort of focusing further upstream to support folks before they're in crisis and to figure out how to provide meaningful, accessible, and safe services to people so that we're not leaving them until they're in crisis. That's a bit of a blathery answer, but there you go.
Yeah, I appreciate that so much, Kendra. Yeah, such food for thought, like how much of these problems are created by the fractured system itself. Yeah. So our next question is for Jonny. So Jonny, I know you have a lot to say as well about public funding. I'm wondering if have you noticed any shifts lately in that area, and in your opinion, where is funding needed for mental health care?
Well, and just to say to Kendra, it wasn't blathery at all, and sometimes the best is blathered. So, but it was very clear what you were saying, Kendra, there of I think some of the the profound impacts that we see in a crisis-orientated system where there's increased levels of coercion. So I just wanted to say to Kendra that was very cogent. Where is money needed? Well, I would say, and I've been in community mental health for 25 years, and I have such deep respect for what Shobha and Arthur and Kendra have said. I mean, ultimately, it's in community. It's in providing closer to home, community-driven, community-based care that brings people with the expertise that comes with experiencing a mental health or a substance use problem into the design of programs and solutions going forward. And community, and I know community is a definition that we can trouble and contest and pull apart, but so much happens in community, whether you're in Terrace, whether you're in Kitimat, whether you're in Prince George, whether you're in Vancouver, whether you're on the downtown east side or on Pandora in Victoria, wherever. Community is where so much of the collective knowledge, the ways of knowing, doing, and being, where so much can happen. Now, there's a whole host of reasons why community is under-resourced or under-prepared to respond to the challenges that my three colleagues and you, Adrian, have discussed today, and earlier Tanya as well. And that traces to the legislative regime we have in place in this country. And so we have a Canada Health Act that, and BC Civil Liberties and the doctors of BC have taken a look at this issue over the years, which allocates particular kinds of funding for particular kinds of services through the transfer agreements from the federal government to the provinces and territories. And that drives how provinces and territories allocate their money into community. And so the softest money going is community money, because that piece of legislation very much privileges the funding of hospitals and formal health systems around mental health care. So, you know, there's an opportunity, I think, to take a look at what the newly installed federal government has promised in this regard, and they've promised, you know, we have a new federal cabinet minister, we've got commitments around standards and other flows of money. But I would say there's a really important conversation that needs to get restarted around the Canada Health Act and dedicated funding streams for mental health care that lands in communities, and where you can follow the dollar from when it leaves the federal government and it ends in community, and you can see that it has the desired impact within community organizations. We've made progress there. The Health Accord that was negotiated a number of years ago transferred money into the provinces and territories specific to mental health. It was part of the Health Accord signing process. But there's an inherent vulnerability to that money because it's attached to the political regime that's in place right now. And I think many of us would want to see that hardwired. You know, there are conversations provincially around expanding dental coverage, which has a huge and profound linkage to mental health, by the way. Oral care and mental health, very, very linked. And I think there is a growing conversation here in this province about doing the same for psychotherapy and care. I think it's really important to state that there is progress underway and there has been change made here in what's now known as BC, in and around community funding. And there's a lot of narratives, a lot of stories, but I think of the work you oversee, Adrienne, at the Community Action Initiative with regard to community counselling grants. Now, arguably the investment is a drop in the bucket of need. But the resourcing over the past number of years for community-based agencies like neighborhood houses, family associations to provide low-cost or low-barrier counseling services, much like Native court workers do, is profoundly important because it started to remove cost from the ability to access care. And I think that's a good example. It's one of a few where there has been an emphasis on the value and the role of community agencies, community social sector agencies in providing the care in the ways that we know how to in partnership with our communities. And so what I'm referencing is the Community Counselling Grantee Fund that was launched 3 years ago. And currently there are 50 agencies in and around the province delivering low cost or free counseling. But are overburdened and over-demanded because the need is so great right now. But I think it's really important to say, yes, we have to change things. We have to find ways to better support the community sector to deliver this care. And there is evidence of progress in that area that we have to shine a much brighter light on to prove out both the human, which is the most important benefit, the human benefit, the social benefit, and the economic benefit of relying upon community partners to deliver high quality care in community, wherever you are in BC. Mental health care in this province should not be a postcode lottery. The kind of quality of care or access to care should not depend on where you live. There's a comment in the chat about a universal human right. That's a big push from CMHA nationally of really trying to get us all on board that mental health is a human right. We have a right to human health, mental health going forward. So those would be a couple of comments. The last thing I would say that was really interesting that I don't think has been taken up here in BC around where public money should go in mental health care. Before the Liberal government fell in Ontario a few years ago, one of the pledges that was made was a renegotiation on the funding formula for community agencies in the provisioning of mental health care. There was a look at the fact that costs go up and community agencies struggle. And I thought it was a really good example of policymaking, of a negotiated lift for community sector agencies that are often 3-4 steps removed from government. They're in health authority contracts or other contracts. And I think there is a conversation in the community sector that could have around the fact that for many community agencies, they are the front line to the drug poisoning crisis and all of the harms that come with that upon worker mental health too, the moral distress. We have an overtaxed community sector. And so I think really thinking through that we can't be left behind as a foundational block of provisioning mental health care in this province. And if all of us were to disappear overnight, if Arthur's organization were to disappear, CMHA, Health Justice, Central Interior Native Health Society, if we were all to disappear overnight, we would be hooped when it comes to the provisioning of care. And so what does it take to level that playing field to make sure we can provide quality and acceptable and appropriate mental health care going forward? I hope I started to answer your excellent question there, Adrian.
Jonny, you have a way of speaking where I just feel like I always want to be here with pom-poms. So yeah, thank you so much for just laying that all out for us. So this next question is kind of an open question, bringing us all together for whoever wants to kind of weigh in. So we've kind of laid out the issues with our system and the barriers historically, currently, how those interact. As we start to vision a new way to move forward, I just love if we could articulate maybe a bit more precisely, I guess, what is the difference between an institutional or medicalized approach to mental health and a community-driven approach to mental health? So specifically interested in regards to culturally specific care, especially Indigenous-led programs for Indigenous communities. What does the decolonized approach to mental health care look like?
Adrian, this isn't a free for all, hey, all of us.
No, it's free for all. So yeah.
I'll be super brief here because I think my colleagues will layer on really important components here. I would say decolonizing from my perspective as a settler, as an immigrant to the country myself, as a racialized person as well, just to locate myself a little bit, is finding ways for knowledges and ways of healing and doing and being to no longer be squished and squashed and hidden away underneath a fairly dominant way of thinking through mental health care and substance use care. We have big, powerful forces and vested interests around the kinds of care that get provided. And a lot of that is driven by Western psychiatric ideas, which absolutely are very helpful and very powerful, but are limited when it comes to thinking about transcultural mental health, what mental health means transculturally or cross-culturally, across genders, across ages. And so I think finding ways for other forms of knowledge to be valued and applied to care is so critical. And at CMHA, and I know this is important for my colleagues, particularly Health Justice, finding ways for the knowledge of someone who's experienced the system, in quotes, and how that knowledge can be brought forth in a respectful and meaningful way to ensure that the programs that we create go forward, I think is a really important thing to do. In the chat, someone's flagged the South Asian Mental Health Alliance. They're doing brilliant work. They have thousands of people engaged in that work because they're coming at what's known as mental health or mental ill health in ways that are responsive to the cultural meanings and ideas and concepts around mental health within those community groups. And I think that's powerful. I think of the work of Viker on the island, a community counseling grantee agency that provides mental health counseling to immigrants and refugees arriving in Canada. And they bring one of the most robust trauma-informed approaches to providing care to those communities, which I think is a way of disrupting traditional ways of how power circulates in providing care. They do beautiful things at Viker, well worth looking at. Because I think the models that we have at play won't get us to where we need to get to, especially when we think about land and we think about security in an age of massive climate disruption, when we think of profound existential threats to who we are as human beings. Psychiatry and psychology and those ideas are very helpful, but we will not be able to maneuver out of distress by simply applying those singular forms of knowledge, treating, as Kendra said, disordered individuals. There's a whole world happening around us that's creating disorder. So we actually need to start thinking about intervening with those conditions of disorder. Often suicide is thought of a problem inherent within Indigenous communities. It's not being Indigenous that causes a high rate of suicide. It's intergenerational trauma, ongoing structural racism, and lack of provisioning of the basic needs for communities to live and thrive, including drinkable water. And so, I think we need to think about where we intervene with the social conditions that create distress. And I would humbly hazard a guess that a decolonizing approach might lend itself to thinking about other sites for intervention. I got on a very passionate thread there, Adrian. My apologies.
No need to apologize. Yeah, that was really good points there. Would anyone else like to weigh in?
I would just add, at Health Justice, we have, as part of our governance structure, a just wonderfully brilliant Indigenous leadership group. And one of the members of that group often reminds me to pathologize systems and not people. And I think that applies both in terms of sort of the huge social issues that Jonny's talking about, but I also think it applies to Arthur's example of, breaking up a family unit when you're trying to fundamentally deal with intergenerational issues and treat a family as a whole collective about how they interact with each other. And so I think the way we design systems often, when it comes to mental health, I often think of the medicalized model as trying to, when surgeons are doing surgery and they put the sheet over you and they just have a little hole so that they're just working on that one thing they're doing surgery on. We try to do that with mental health, and we try to sort of put people into these narrow boxes and treat just the box. But actually, we know that everything in their environment, from a personal perspective, in their community, at a systems level, nationally, internationally, that all impacts their mental health. And so for me, a big part of moving and sort of giving us tools in addition to medicalized models are thinking exactly as someone just said in the chat holistically, is not assuming that we can have that really narrow focus to fix things that are impacting our wellness that we know are coming from all around us.
I've got my pom-poms out. I just want to speak for 2 seconds on that, just to say that I agree completely. And that was really, when I look at what a decolonized approach to mental health looks like, it's really about, we have to break that structure that creates linear thinking, and understand that there's circular thinking. So again, when Arthur says that a sex offender is not permitted to access that funding, well, was that sex offender a residential school survivor? What are the pieces that have created situations of trauma, and what are the situations which have created actions, and to humanize individuals again and again, to understand that we have to be able to look at care as person and family centered. We have to be able to understand them in a larger context. within Central Ontario Native Health. It's been super important for psychiatry to work alongside mental health supports for when we're doing pharmaceutical alternatives or opioid agonist therapy, that we link that to our wellness team. So how do those individuals receive the outreach to address their social determinants of health, to address their trauma, because it's all interconnected. There's not one solution usually, there's usually many. And so really looking at things in a circular unit, and taking those categories away, stop thinking in a linear fashion, but looking at the connectivity of everything and looking at that Indigenous worldview of everything is connected. And so how can we help this individual build those lifelines again if they're gone? I'd love to pass the honor over to Arthur.
Thank you. I have to agree. I have to agree with all of you. The integrated community approach is by far greater, and in the end, it is actually cheaper because you have a full community attempting to assist an individual. Although there is a lot of training that you specifically provide to the community support people that are in that are willing to serve an individual with mental health issues. And it isn't just as individual families problem, it's a whole community's family issue because it is community integration. If there's anything that happens within that community, you have to make the whole community understand. Your next door neighbor has to understand, the people who live upstairs have to understand what the family may be going through if they're having an individual with a community with a mental health disorder. So I agree with every one of you, and really we here at our program, we push for community integration, the major source. I just had the city councilors here and we talked about who my next door neighbor is, how I know all of them, and how we do community block crime prevention here in our office with every one of our individuals. And when they lose family members, they actually come over and talk to us and we counsel them. So it's beyond the context of actually just having somebody walk in or a counselor being referring an individual over. It's actually everyone, because we're all affected by it in some form or fashion. That's why we stay up late at night. So I agree with each one of you. I think that, as I mentioned earlier, the funding aspects, limitations that that our funder has, one of them. And basically, for the last 25 years in this program and 40 years in the field, I've not been funded by a funder. I don't get paid by a funder. For 10 years, I worked for free. And it wasn't until the CAI community came in and said, hey, we know what, we can actually contribute to the supervision. I was like, wow, there's money. That's cool, I get paid. That was the biggest one. And on a yearly basis for close to 10 years, I used to go to our funders board meetings and raise my hand every year for 10 years, saying, I would like to know by raising your hands, who works for free here in this room? Just please raise your hand with me. And I got to the point where the board was just kind of looking at me going, are you going to do that raise hand thing again, Art? Yes, I am. Because I need you to understand that I work for free. And I don't understand why anybody else is not. And why don't you fund us specifically for that purpose? And so it's educating funders as well, trying to get them to understand that some of the services that we're providing, you are all looking at nonprofits doing the best service, providing the best service, but we're at half the rate and half the cost, if not half the cost. You don't charge. I don't get paid at all. So you're kind of going, that's pretty good rate. That for the government to go, hey, this program's running well and we don't have to pay the clinical supervisor. That's wonderful. You're saving money. But yeah, that's just one of my rants. And yeah, I think Jonny probably understands. Thanks.
So for our last kind of scheduled question, this is for Arthur and Shobha. So the reason why we invited both of you to be on this panel is because you're both doing work in organizations that are real exemplars of showing how mental health care can be done in community in this really integrated way. And so for those of us on the call who may be struggling to imagine what that can look like, I'm wondering if you can just kind of describe the work that your organization is doing to give us an idea of how this can be actually operationalized, how it can be like a tangible thing that we can all do. So yeah, Arthur or Shobha, you want to start?
Go ahead, Arthur. Did you?
Oh, sure. Okay, so what, just to give you an idea specifically what I formalized here 40 years ago when I first started working for the Native Courtworkers, working with Courtworkers as a board member, director of sustainability for raising funds for them, and then developing programs. And one of the issues of what we've done here through Vancouver is that we have the Native Courtworkers, which deals specifically with the justice part. So Kendra, we're in a good relationship. So we did the Courtworkers first, and once we started with the Courtworkers, we started realizing that you had to do a survey and you had to find out why individuals actually are in the institutions and being charged, and they're not taking bail, and they're all pleading guilty. So we did the survey and we realized that 97.7% of them have an addiction of one form or another. Hence, the other piece of was mental health. And then we actually said, you know what, we need to get these individuals, they need to detox first before they can actually come into addictions counseling and understanding their mental health and where they are. So we did Courtworkers, detox support workers, A&D counselors. We have family advocates that specifically are in the field that we actually utilize for our families, because if we can't deal with Joe, then somebody else can spend a little more time with Joe and Jane and little Joe and Jane. Then we have elder support, specifically when an individual starts working with their family and they start getting healthier, they start asking questions concerning where they are. What's their traditional cultural background? What language should they actually be practicing? Where can they actually start developing their respect and honor for their positions and what we teach here at our program? You've got to relate that we're Indigenous, serving Indigenous, speaking language, practicing our traditional cultures. So each staff member specifically is that, and so they have that to offer to our clients. So elder support, specifically one where we actually teach individuals. So individuals don't just come from Vancouver, they're urban. So they come from right across Canada. So we have to find elders specifically from right across Canada, or have a knowledge or a good understanding of traditions right across Canada. We're really lucky with the Métis Association, and specifically we have knowledge keepers there, which we actually use for Métis, and that seriously has helped us quite a bit. We have mental health workers, specifically Indigenous mental health workers working for Vancouver Coastal Health, who we pull into our office, and he happened to be working for me, and I trained him, and he now works for Vancouver Coastal Health. So I use him as our mental health worker. Specialized counselors working in the field of FAS, HIV, and AIDS, the specifics. And again, been very lucky in educating and training individuals in the field who are Indigenous, and that we send them to those individuals. They work for another agency, but we still send them to them. We're lucky here again. I've trained in this last 2 years 6 therapists, Indigenous therapists, and signed them off, and they're now therapists, and they actually work for me. As I said earlier, 2 of them have come into the office twice a week. They work for me, and the loyalty is here, and they keep coming back every day or every second day. So I love that piece. And more Indigenous therapists would be by far better, because that would help them understand what we're going through here. After hours workers, one of the questions I always ask everyone, funders, I ask therapists, doctors, you name it, I ask, what do you consider a healthy client? What's a successful client to you? What do you think a healthy client is? And majority of the time I get all kinds of weird responses, but some are good, some are phenomenal, they add to mine. But mine is a successful client is one who becomes a peer support worker for your program. That's the only way that you can actually ensure that they actually have learned the skills, maintained the skills, and actually use the skills in the program that we actually have taught them for the time that they've been here. It's usually a year to a year and a half. So they become our after-hours support teams. When we lose any one of them, it's such a great loss, and we've lost a few in our community in these last 18 months. Residential treatment, majority of the residential treatment workers and the counselors in the Indigenous field, they've come here first. They've done their practical placements with us before they've gone off and worked at the institutions. So I'm really lucky about being a part of that. We have restorative justice. They were supervised and monitored by us here at this office. Correctional workers, we have prison liaison workers who go in the institutions. So if an individual gets sentenced, we're still in touch with that person. We don't let them go just because they go into correctional institutions. So we have prison liaison workers that keep that contact. We have an Aboriginal resource worker. So when an individual comes out of a correctional center, they specifically keep contact to make sure that the person is still successful in their probation or parole. And they still contact with their addictions counselors. We do community reintegration because that's the key to success. If you're looking at reintegrating somebody to go back into a community or a new community, or in developing a new community and a new family for them and changing their behaviors, that's the piece that we do the majority of, because that's what makes us successful, because that community starts taking care of the person. And we heavily rely on a lot of the resources, and we do, we on a continuously, every year we have a gratitude ceremony where we list off all the agencies that we support and we don't forget about them. And I think that's the most important key to your communications and partnerships, is if you don't forget about them and you name them and you give them a gift and you show gratitude in an Indigenous ceremony, that they start to going, wow, well, you're recognized. My hats off to knowledge keepers and elders, because we use them quite a bit. And when we lost a couple, it was horrible. We have First Nations courts that I'm really proud to be the originator of, and I have elders there, and I've just lost 3 elders in one of our First Nations courts, and I'm like, that's horrible. But that's a part of the piece that we do, is we follow up is the key to our success. We never leave an individual alone. We follow them for 2 years, and we try to ensure that the community still has the resources to actually continue to come to our program and learn new skills and be supported. Yeah, that's the program that we serve. And traditional culture is for us is the key to our success. We teach it, we talk it, we live it, and we share it here as much as we can with anyone. I have approximately 10 practicum students throughout the year. I just finished working with 2 nurses. And so I'm always trying to teach and always trying to share. I mean, that's what I always taught, and that's what I teach my staff. Thank you, Adrian.
Thank you, Arthur. Yeah. Shobha, can you tell us a bit about your organization and how it works?
Absolutely. So Central Ontario Native Health is an integrated primary healthcare center, and we have been at the forefront of trying to decolonize primary healthcare for those that we serve since the 90s, since we came into inception. And really the biggest piece of that was to create a large community. Kind of what Arthur was saying was that connecting with community organizations and educating them on what colonization, the impacts colonization have had, but not just colonization. Because we provide an equity-oriented healthcare model, we're able to reach those that are precariously housed, those that are living on or close to the street, high-risk moms, high-risk youth that are at risk, as well as those that are working through and are at risk for HIV, HCV, TB. And so I guess our initial approach was being able to create a community so we can create care coordination. It's one thing to be able to receive services in one way in one location, but how do we ensure that their entire health journey is one that is met and can build on trust, and to give them the security that they need to continue to work through any challenges they do have? And so that was building partnerships with the communities around us. Another piece was ensuring that we are an educational space. So we bring through physiotherapy students, we bring through OT students, we bring through RN students, medical residents, medical students, and all of these individuals come through to learn cultural and trauma and resiliency informed practice. And by doing that, we feel that we can then create a community in which individuals will be able to be approached or treated fairly, justly, with respect in other locations as well. One of the biggest pieces that we've been doing in regards to mental health is growing our interdisciplinary team to include a really strong Indigenous team, a team that can help us approach harm reduction through culture. And so again, when you're looking at trauma, the only way to deal with trauma is not opioid agonist therapy in all cases, or traditional forms of, or Western forms of mental health supports, but being able to say that culture itself is a form of harm reduction. Culture can help to resist colonial structures. So we've actually created an entire space here at Central Ontario Health called Netsulius, and in Decal, it means let us rest. And it's a place for our clients to come in and literally be a safe space for them to come in and not have any plans to see a mental health clinician or to see a wellness counselor or to see one of our providers, but it's a space in which they can come in and breathe for a second. I can't forget the moment one of my wellness counselors came to me and said, sometimes our clients just need to sit for 15 to 20 minutes, but they're tired, they've been on the street all day, and they just need 15 to 20 minutes before diving into their healthcare needs or their social determinants of health needs. And so that really made us think, how can we just create a warm and welcoming space in which they feel safe, they feel secure. And in addition to that, then provide them opportunities to practice culture. As Arthur said, like using language is key. And we're not just serving the Decal people here, we're serving people that have been displaced and are coming from many different nations, but giving them an opportunity to reclaim identity means that they have a stronger sense of self and who they are, and that helps to build resiliency. And that's really what we need to move towards, is not feeling sorry or feeling like we need to take care. That's a very paternalistic way of approaching a situation. And Indigenous culture is strong. When I did my master's, I remember being penalized for using the word loss, because there's never been a loss of culture. Culture has been they've tried to restrain culture and prevent culture from being practiced, but culture is not lost. And so using culture as a form of harm reduction is huge for our organization, being able to provide our clients with a space to come into and then to be able to do work like harvesting, foraging, being able to connect again with the cultural practices that they once used to practice, and be able to give a space for them to teach others and to share with others or to learn for the very first time. That to us is an opportunity for them to decolonize structures, but also to be able to reclaim self and to be able to strengthen their mental health and their goals for mental health. And so I know that we are short for time, so I'm just going to end there and leave it to individuals to ask questions.
Well, that was just so beautiful. Yeah, thank you so much for walking us through Netsulius and yeah, the way that all the things that it offers to people. So this next section is our Q&A. Yeah, so yes, thanks again to all our fantastic panelists for sharing all your insights and experience. So for the Q&A section, just a reminder to people on this meeting to feel free to submit questions using the Q&A box, but not the chat. And please specify which of the panelists your question is for. Although unfortunately, we do have limited time together, so we might not get to all of the questions. So I just do apologize for that in advance. But our first Q&A is from Liam McClure. So this wasn't for anyone. So any of our panelists, just feel free to pipe up if this resonates with you. So their question is, how do we help enable marginalized communities to take control of their mental health when relationships between dominant culture and those communities is fractured or broken? I'll just read it again so you can have a minute to think about it. How do we help enable marginalized communities to take control of their mental health when relationships between dominant culture and those communities is fractured or broken? Shobha.
Yeah, I would just quickly say, and then leave it to everyone else, is that find knowledge keepers and elders and build resiliency from within. I think there's strength in building from who you are, and I think that that then enables individuals to gain strength.
Thank you.
I might chime in quickly here. Adrienne, to say it's a great question from Liam, who I know is quite familiar with some of the peer-assisted care work that's happening. And I think of the example of CMHA Northwest Vancouver that's leading the implementation of a peer-assisted care team that has worked very closely with communities that experience marginalization or vulnerability to build out a team that reflects the needs in community. And so rather than a cookie cutter, one size fits all approach, they built a team that speaks to some of the points I made earlier and others around this panel of having something that's built by community, owned by community, even at that very basic level of linguistic accessibility. So to have a team that speaks languages that reflect the community in which the team operates is a way of, I think, democratizing access to care, reducing reliance upon these pipelines to care that can be coercive and traumatizing at times. And so, I think the recent piloting of a peer-assisted care team in community, other cities are very interested. This is a way for communities that experience marginalization to experience a degree of control and agency when it comes to accessing the right care at the right time.
Thank you. I just see one other question that we have time for. Probably only have time for one or two folks in the panel to answer this, but this one's from Ken Collier. I hope I said that right. Their question is, all the provinces and territories plus the feds have many studies, commissions, and task force reports with multiple proposals about mental health. Do you see any signs that governments or agencies are adopting them?
I'm sure Kendra would have a lot to say on this one.
Yeah, I mean, I'm happy to say specifically in the area, of course, of an involuntary mental health and substance use care, the issues that like health justice is working on right now have been part of the conversation since at least the kind of mid-1990s in BC, and there are many federal reports. It's part of the Kirby report. It's part of, there's been repeated ombudsperson's reports going back to the early 1990s that are all pointing out the same problems. And so I hope that there's sort of this increasing conversation around mental health, and particularly in response to COVID will help sort of create some momentum around those things, but it is disheartening. And when I think back to Liam's question and helping marginalized communities take control, I think the first thing we can do is ask them what's getting in their way, because we often don't, and we just sort of keep plugging along in the way we build systems. You know, I've already heard a bunch of examples today of things that are kind of small, but actually might fundamentally change the way a family or a person could engage with care. So I'll leave it there and hopefully make space for others.
I'll be super brief because I'd be keen to hear from Arthur and Shobha. I would say that there is some degree of progress, particularly I think in the area of reducing reliance upon police, who've become in so many ways the default responder to mental health crises. And for a number of years, we and allies have been calling for health responses for health conditions. So if you're experiencing a mental health emergency, have a health response as much as possible to that. And so, you know, I think of Commissioner Govinda's report yesterday and her commission's calls for really looking at health responses for people in emergency. And I can see that traced into a mandate letter of at least 2 ministers here in BC of trying to find a way to course correct on an over reliance upon police in responding to mental health. So I do think it's in some context there absolutely is action. I don't think it is true to say we are completely stuck. I would say there is movement. I think the question is, for true paradigm change, do we want to tinker our way to change, or do we really want to look at some of the reform that's required? And I think you can both tinker and reform at the same time. And the very fact that, you know, agencies have received support from the province to try this out, I think is evidence of taking a look at those reports and acting on. But I think in the area of coercive care, there have been countless reports, and I would argue that it's agencies like Kendra's that will lead the way in compelling action in that regard, because I don't think enough action has happened, particularly in the apprehension and detention of people in crisis. So there is movement.
There was one last question that I just remembered. This is from the BC Health Coalition. So just putting it out there for all the panelists, like what can the BC Health Coalition do to support this kind of movement, this paradigm shift that you're talking about, Jonny? Any ideas?
I would say, and I love the comment, this is not the time for small ideas. I love that comment. I would say change is brought through dialogue. I don't think we should underestimate the power of things like this that the coalition have convened, because dialogue pushes back stigma. We can sit with story. You know, I have my own lived experience of mental illness. I have a family member who lives with mental illness. We can have conversations that just push back the edges of stigma, which disenables change to happen because people don't feel safe, people are coerced, all of those things. So I know talk is not enough. It's absolutely not enough. We don't want to just sit around and talk all the time and not act, but dialogue, particularly given that many of us have been atomized and we're at home behind our computer screens, and our ability to build coalitions and work together has been impacted by being remote. I think bringing people together like you have, Adrienne and Tanya and Audrey and the rest of the crew, is so powerful for, kickstarting some of the change that's required, and not underestimating what happens when we all leave this Zoom meeting in 12 minutes and the connections that might form, and the alliances that can work together to continue change going forward. So I think what you've done today is powerful and should not be underestimated.
Thank you for those words, Jonny. I think that's a great way to kind of close the panel. Please join me in any way that you can, wherever you are, in just thanking our panelists for their time and expertise. So grateful for all of you. So I'll just pass this on to Edith.
Hi, everyone. I want to keep talking with all of you for the next 3 hours. So thank you so much. And I just feel so grateful to be able to hear your words, your stories, your experiences. And I've learned so much from each of you. So just a couple of really brief remarks. Our health coalition hasn't historically worked on mental health care, but we've been active for many years in advocating for team-based primary care in community, and strongly believe that includes mental health, and that is responsive to social determinants of health. So we just wanted to briefly touch on two different areas. So we've been involved in advocating for community health centers because we know that the evidence supports this model in community. There are already a number of community health centers in BC that operate on a similar model as the Central Interior Native Health Society that Shobha described and works for. And we just wanted to highlight the 5 pillars. They're on the screen now. So there's, these are aspects of community health centers specifically. This is how we define them. But these are all aspects of healthcare that I think could all hope for. So they have multidisciplinary professionals. There's a wraparound approach. They're governed by the community and also accountable to the communities they serve by board representation. They work upstream to address determinants of health, like access to housing, food, and employment. And they're also justice-based and promote health equity. Primary care networks is something that most of you will have heard a bit about in BC by now. And so as they evolve, the Health Coalition has paid close attention and advocated for community involvement, and also the inclusion of mental health care in community. And so this is an example from Burnaby. So primary care networks are located in a geographical area. So several care networks, such as the one in Burnaby, are moving towards including providers beyond family doctors and nurse practitioners. So for example, Burnaby includes mental health professionals so that mental health care is integrated into that primary care level. This allows family doctors to work more closely, it just offer more holistic care. PCNs can also include community service organizations, and we see that this is a great strategic step to reduce barriers in primary care because it connects primary care providers to organizations with strong presence and connection in the area. So for example, newcomer settlement organizations have been able to work closely with the PCN in Burnaby to address barriers to newcomers and immigrants to primary care and COVID care during this past pandemic. So when it comes to mental health, community organizations will play an important role in ensuring that primary care networks provide culturally competent mental health care. Our advocacy work in primary health is ongoing. We definitely encourage you to get in touch with our team by emailing info@bchealthcoalition.ca. That will be included in the chat box if you're interested in getting involved. So even though we work in to improve primary health care and we want to see more upstream approaches, more holistic care, we know that many people in this province still rely on crisis intervention. So crisis services are an invisible mental health safety net that often go unrecognized, and they need to be properly resourced and funded. So some of you may not know that our crisis intervention and suicide prevention centers are currently under threat in BC of being privatized across the province. We want to invite you to take action today to support this important work. So I'll invite Ayendri, our campaigner for the BC Health Coalition, to just describe our upcoming campaign on this matter. Ayendri, are you able to?
Sorry.
Great, thanks.
Sorry, folks. As Edith has already mentioned, I'm the campaigner for the BC Health Coalition, and we are campaigning right now to save BC's crisis lines. The BC Crisis Lines Network, comprised of 10 local crisis centers, answer calls to 1-800-SUICIDE, 310-678 mental health, and regional distress lines, providing life-saving crisis de-escalation, suicide risk assessment, and strengths-based collaborative safety planning and follow-up to vulnerable British Columbians across the province. The Crisis Lines Network has recommended for years that the BC government increase funding to meet the rising demands for services and centralize the technology so that they can, that all crisis centers across the province can support one another's calls. The province is finally heeding that advice, but instead of directly awarding this increased funding to the nonprofit network that collectively has 515 years experience providing services, the government has chosen to put these contracts to competitive bid. This not only delays or disrupts essential services, but it also raises the strong possibility that crisis services could be taken over by a multinational for-profit corporation. Just to draw on some of the pieces that were mentioned during the talk, Kendra had mentioned, the strong preference to fund crisis, but also fund a certain type of crisis. This process has the possibility of impacting our crisis lines. It's far cheaper. We know that it's far cheaper to fund referrals or to do referrals than it is to actually de-escalate. And it's also less liability and cheaper to refer to at-risk callers to 911. So how our current crisis lines system works and network works is it's deeply integrated with other supports, follow-up care that is necessary to actually have a holistic approach to this work. The government has stated that they will communicate or finalize their decision to put crisis lines to competitive bid by December 1st. This means we have a tiny window to raise awareness and show support for this essential mental health safety net. we are launching an action. Unfortunately, we have had some technical difficulty in launching that action, but we will be following up with an email to ask everyone to write a letter to the editor. I personally love letters to the editor because it gives people a chance to kind of voice some of the importance of mental health supports, voice their opinions. There'll be choices to send and options to give you kind of templates of sending that letter to the editor, but showing support for crisis lines and mental health and publicly funded non-for-profit mental health services is really important at this very specific moment where there is funding being increased, and that we wanted to go to non-for-profit and public service providers, and we want to make that push strong. So we're asking everybody on this call who joined us today and all of our members to share this action. And in the upcoming days, we'll be sharing it with you. So thank you.
I don't know if Tanya is able to just
my mute,
close us
sorry.
up.
Yeah,
Thank you.
sorry. I was chatting away on mute as usual. Yeah, I was just saying that's a wrap, and that I really want to thank everybody, particularly the panelists, for sharing with us, and also for the team that put this together. It went very well, and thank you. We also have a strategic planning session that's going to be coming up in the new year. So please keep an eye out for an invitation to that, as we would value any contributions that come forward. So thank you again.
Thanks, everyone. Be well.
Thank you.